Hello, I'm Dr. Jeffrey Weber. I'm a medical oncologist at the Laura and Isaac Perlmutter Cancer Center here in New York City. Today we're going to be talking about a very hot topic of neoadjuvant therapy. In the February issue of Nature Medicine, there were two articles on neoadjuvant therapy. The first one was by Alex Menzies et al. From Australia, and this was an article in which a compilation of neoadjuvant trials was summarized and the clinical data were presented. There were 192 patients that were summarized altogether. 141 had neoadjuvant immuno-oncology drugs for patients with stage 3 palpable, stage 3B and 3C melanoma. That was resectable. And 51 had targeted therapy. And the pathologic complete response rate, which in many other cancers is a very important clinical indicator, was 47% for those with targeted therapies, only 33% for the immuno-oncology group, but it turns out that the rate in the combination immunotherapy group was actually 43%. For the pathologic complete responding group, 2-year relapse-free survival was an excellent 89%. It was only 50% if you had no pathologic complete response. If you look at overall survival for the pathologic complete responders in the total group, 95% at 2 years versus 83% if you didn't have a pathologic complete response. If you had any pathologic response, which means pathologic CR, near CR, which is 90% of tumor regressed, or pathologic partial response, which is 50% of the tumor area regressed, your 2-year relapse-free survival, 96% with immuno-oncology drugs, which is pretty darn good. For the targeted therapies, the PCR overall survival, an excellent 91% at 2 years, but 99% for those who got immuno-oncology drugs and had a pathologic CR. So clearly having a pathologic CR is incredibly important clinically, and it looks better to get a PCR with immuno-oncology drugs than targeted drugs. If you relapsed off targeted neoadjuvant therapy, 13 of the 17 relapsed in the brain, only 3 of 15 who had immuno-oncology drugs, and that seems like a big difference to me. The median follow-up of the entire group is only 18.8 months, so this is modest. And 7 of the immuno-oncology patients did actually progress before they could get to surgery. And on average, patients got 6 weeks of neoadjuvant therapy, although this was a mixed bag, and some of the patients in the IO group actually only got 3 weeks, meaning a single dose of pembrolizumab. Most of the others got 2 cycles of immuno-oncology drugs for a total of 6 weeks. So this was a somewhat heterogeneous group. If you look overall, landmark overall survival at 2 years, 87%, which I must admit, for the whole group, again, remember, some targeted, some IO, is not all that much different than what was presented by Acierto et al. In the Checkmate 238 data on survival at 4 years. So again, we'll see whether there's a difference. And again, looking at the combination immuno-oncology survival, 96% at 2 years, very impressive. Only 78% for monotherapy, suggesting that you'd probably rather get combination than monotherapy. Again, if you had a RECIST response on scanning before going to surgery at the end of your neoadjuvant therapy, if you didn't have a RECIST response, almost all those patients had no pathologic response. If you had a RECIST CR, almost all those patients had either a pathologic complete response or a near pathologic complete response. And again, it seems like with immuno-oncology drugs, any pathologic response, pathologic CR, near CR, or pathologic partial 50% response is useful. And again, all those patients had an association with relapse-free survival, whereas only the targeted pathologic CRs had an association with relapse-free survival. So the authors felt that the achievement of a pathologic CR probably should become a new endpoint for a drug assessment and approvals, which I think is a reasonable position, but the follow-up is modest. But they definitely are correct in saying that these data are grist for the mill to do randomized studies of neoadjuvant versus adjuvant work. Now, there was a second, a smaller study, which was also on the neoadjuvant spectrum, and actually some of the patients in the second work in the same issue of Nature Medicine by Roseman et al. Were contained within the Menzies overall group. But by Roseman et al., the work was a study of 2 studies, the Opacin and the Opacin Neo studies. Opusyn only had about 20 patients, and only 9 of them, I believe, got combination immuno-oncology drugs and were included in the current article. And 86 patients were in the Opusyn Neo study, which is a 3-arm study of neoadjuvant 2 cycles of Ipi-Nivo and Ipi-3-Nivo-1, 2 cycles of Ipi-1-Nivo-3, or sequential nivolumab and ipilimumab for a total of 4 injections, which would essentially be 2 combination cycles, all spaced over 6 weeks, followed by surgery. In that study, the Opusyn had 4 years of follow-up, which is actually pretty impressive. And in the 7 out of 9 patients who had a pathologic response of any kind, no relapses, but small numbers, 2 years of follow-up for Opusyn Neo, and 86 patients, 84% relapse-free survival in this immuno-oncology neoadjuvant study. If you had a PCR, your RFS was 97% in 2 years, whether you had a PCR, near PCR, or a pathologic partial response, but only 36% relapse-free survival in 2 years if you had no pathologic response, which means less than a pathologic partial response at 50%. The authors looked at a number of biomarkers, and they looked at tumor mutational burden as well as the interferon gamma signature that we're now familiar with, that's associated with outcome with a number of immuno-oncology drugs. And as you would expect, at baseline, high TMB, high gamma interferon signature associated with both relapse-free survival and pathologic response of any kind. And again, if you had a high tumor mutational burden, high interferon gamma signature, 100% pathologic response. Again, very impressive data. And for the whole population of Opusyn Neo, 2-year survival turns out to be 95%, and there's no real difference between the arms. And toxicity, much lower with what they called Arm B, which is Ipi-1-Nivo-3, no big surprise, at about 27% grade 3, 4, 5 IRAEs. But 27% of the patients overall needed hormone replacement, or 21% rather needed hormone replacement, and that's a fairly high number. And again, with the immuno-oncology drugs, baseline tumor mutational burden was associated with event-free survival in any way, shape, or form, 93 versus 56% at the median of tumor mutational burden. Both markers were associated with pathologic response. And again, as you would expect, if you had a low tumor mutational burden, low gamma interferon signature, those patients had poor survival and a poor level of pathologic response. And again, the gamma interferon signature contained the expected genes that were expressed, including CCXL9, 10, and 11, gamma interferon, STAT1, CCR5, granzyme A, and IDO1, as well as HLA-DRA. And again, only 1 of 71 patients with a pathologic response of any kind relapsed on that trial versus 16 of 23 who did not have a pathologic complete, near complete, or partial response. The author's conclusions, which I think are quite nuanced and reasonable, is that these data certainly support doing randomized trials of neoadjuvant or neoadjuvant adjuvant versus adjuvant therapy alone. Please feel free to call in with questions. And again, this is Dr. Jeffrey Weber reporting. Thank you very much.